My name is Dr. Syeda Bhukari, and I'll be talking about stress and the heart, mind-body approaches for prevention spotlight on women. So I'll try to do this as quickly as possible in the interest of time. So this is the roadmap for my presentation. I'll be talking about the role of stress in CVD, stress, women and CVD, the role of physicians in this paradigm, and individual level therapies for stress and cardiovascular disease. So what is the premise? We know that Interheart found that stress and stressful events, chronic stress, stressful life events, and depression are a strong predictor of MI with an odds ratio of 2.67, and that neuromodulatory strategies targeting the brain and heart can actually have the potential to provide a new kind of therapy for cardiovascular disease. We know that women have this long life of reproductive milestones, and as rightly pointed out by our previous speakers, protective effects of estrogen are often mitigated by pregnancy milestones and preparing menopause and menopause. And acute psychosocial events can cause acute coronary events in women, and unless there is resolution and adaptation, which does not always occur, and the pro-inflammatory state occurs in women. When we talk about the biological effects of psychosocial stress, there is an increase in inflammation, there's an activation of the neuroendocrine axis with increase in cortisol, and there are also increase in autonomic function with an increased sympathetic nervous system activity. So when we talk about women specifically, we know that psychosocial stress in women is multifactorial, and there are some very women-specific elements to it. For example, socioeconomic disadvantage, childhood adversity, race, ethnicity, intimate partner violence, marital stress, caregiver stress, and the reproductive milestones. All of these are very peculiar to women and can cause a lot of psychosocial stress. This leads to maladaptive responses, which are mediated through two mechanisms: biological and behavioral pathways. Biological pathways include vascular dysfunction, immune dysfunction, and inflammation. And behavioral pathways include disengagement, non-adherence, physical inactivity, increased adiposity, dietary indiscretion, sleep disturbances, and smoking, etc. And all of these predispose to cardiovascular disease. When we talk about cardiovascular diseases which are associated with stress and are more prevalent in women, we talk about mental stress-induced myocardial ischemia, which is more often seen in a younger age and is because of microvascular reactivity. Then we have SCAD, which also has a female preponderance and is seen in young to middle-aged women who are perimenopausal. We also see Takotsubo stress-induced cardiomyopathy, again seen in mostly postmenopausal women, again due to catecholamine storm. INOCA, which is again seen in older women, seen more with smoking and metabolic risk factors, as well as mental health disorders. We have MINOCA, which occurs at a younger age and is caused by predatory disorders, psychological stress, inflammatory disease, etc., as well as HEP-WEP, on which we had a master class already. So when we talk about women, we need to do preventive health care. We should talk about psychosocial stress and work to get this incorporated into guidelines. And further studies are also required in this domain. When we talk about management of psychosocial stress in women, we need to take into account individual level interventions as well as community level interventions. When we talk about individual level interventions, we can talk about cognitive behavioral therapy, mindfulness, biofeedback techniques, stress management, lifestyle coaches, stress education, interpersonal therapy, sleep hygiene, preventive health care. When we talk about community and policy level interventions, we can talk about neighborhood coalitions, community support networks, task shifting from physicians to community health workers. Let's get women the kind of people they actually want to talk about. Geomapping, identifying vulnerable populations and directing resources towards them, and also looking at housing, socioeconomic status, food security, etc., as well as general security, which can cause increased stress in women as well. When we talk about body and mind interventions, how do they work? Basically, they work on the hypothalamic pituitary axis, they work on the central nervous system, and they work on the autonomic system. And through this, they decrease inflammation, decrease sympathetic drive, and cause decreased cardiovascular disease in women. How can physicians help? So there are 4 words here: optimism, positive affect, and life satisfaction, gratitude, and leveraging personal strengths. We should ask them things like, how do you expect things will work for you in the future? and you can reinforce them. You can tell them, I have seen that you have handled the situation very well. We can talk about positive affect. We can talk about meaningful methods in which they can improve their quality of life. We can talk about gratitude. Some women have very difficult lives. We can talk about what did go well. For example, they successfully managed to recover from this disease. And we need to leverage personal strengths. They may be good at something, and let's try to get them involved in those activities and improve their psychological well-being. Some practical approaches can include addressing these issues in the clinical cardiology appointment, doing cardiac prevention and rehab programs, community resources, and psychiatry and behavioral health clinicians as well. When we talk about, then there is also talk about the cardiovascular psychologist who can also help and integrate in the current cardiology clinic and help women with their disease. These are some individual therapies including CBT, biofeedback, stress education, lifestyle coach, sleep hygiene education, etc. And with this, I conclude my presentation, and I would like to send you home with these take-homes, that psychosocial stress is a significant contributor to CVD, especially in women who are vulnerable to more psychosocial stresses. A multi-pronged approach is required, and of course, most importantly, clinical trials need to consider this factor when they talk about cardiovascular disease and addresses it well.